I'd just like to start off by asking that we've seen there's nearly 250,000, approaching 250,000 diagnosed cases of leprosy globally, by the WHO figures at least. Within that, half of that population, the disease burden seems to be centred in India.
Yeah.
Now, what would be the reason behind that? I'd like to get your opinion on that, going around the table, or perhaps starting with Sian first, because you're probably more engaged with the international programme development.
I mean, it's a very good question, and it's a question that I don't think we really know the answer to. I think there's a big gap in leprosy research that we need to find out a lot more about the disease. But clearly it is a disease of poverty, and usually a disease that's found when people are living in close proximity to one another. So when we're looking at issues of overcrowding, then we see that leprosy is often prevalent.
Okay.
So in a sense, when you've got large cities with a lot of poverty, then that's the typical area that we would more likely to be seeing leprosy.
And this, you think, is more accentuated in certain areas, Andhra Pradesh as an example, in India, or just going on the figures.
If you look at the states in India where you see most leprosy, it tends to be the northern poorer states.
Okay.
So you've got states like Chhattisgarh, which has got sort of quite a high tribal population as well, and we know that leprosy, some people have a genetic susceptibility to leprosy. So that's also potentially a reason why we see it in certain areas rather than others.
Okay. You mentioned these, it's intrinsically bound to the cycle of poverty or the elements of poverty, as are all the NTDs in terms of lack of, adequate sanitation and the rest of it. What would be the principal issues from a poverty perspective in terms of what would be the drivers towards leprosy taking hold in an area?
I mean, probably nutrition would be the key factor, but also hygiene and sanitation would play a part. And historically, we've seen as living standards have risen in Europe and Western countries and in post-war Japan, leprosy has gradually disappeared. Okay.
So the structural issues behind once they are addressed, there's a decrease in the disease burden.
Yeah, absolutely. I mean, there was huge numbers of people affected by leprosy in Europe in the Middle Ages, and many leprosariums in Norway was one of the last hotspots in Europe, and that all disappeared before even the development of drugs to cure leprosy.
I would agree with James. It is around the hygiene and sanitation issues, but I think a lot of it is around the awareness of people themselves, of being aware of what leprosy is and how they can kind of care for themselves, self-care for themselves, and how they can kind of raise the awareness amongst communities. I think a lot of the time people come to identity with stigma and being seen as someone with leprosy and kind of hide away and then don't want to come in front of crowds. And I think that becomes a bit of an issue. And I think if people want to come forward, it's the stigma of it will start to go away, just as HIV did. People started coming forward about HIV, people got used to it, and it's just another disease now.
Yeah, I think we haven't got tools like an early diagnostic test for leprosy, for instance. So you can actually have the disease without having symptoms for up to 20 years. So until we've got tools like an early diagnostic test, it's going to be very difficult to get rid of the disease.
I'm sure you tracked the news where President Jimmy Carter was at the House of Lords earlier this month to give the address in terms of the Carter Centre's eradication of guinea worm, 21 different countries, and that was done without drug intervention. And the principal driver behind that was really the education, awareness generation, and stigma, reduction of stigma in those communities. So from that perspective, what could we learn?
I mean, I think awareness and breaking down stigma is really key. And I think the challenge we've got with leprosy, which is maybe slightly different to guinea worm, is that stigma is so deeply ingrained in culture. and I haven't done any sort of research into sort of culture and guinea worm to be able to say that that's totally different. But just, I mean, all the research we've done on stigma in various countries have shown that, in religious texts, in sort of, even in language within communities, then that stigma is so deeply ingrained. So we need to find a way to sort of break down that. Clearly there will be lessons that we can learn from other diseases, from guinea worm, from HIV in relation to that. But I think that's one of the big barriers, because until people feel confident about actually admitting that they've had the disease, they're not necessarily going to come forward for treatment. They don't want to lose their family, to lose their jobs, which actually is often the result of the diagnosis of leprosy.
We would talk about stigma. In your experience, you would have travelled the world, you would have seen these communities firsthand. How does it manifest itself?
I can give an example of a lady in India who, after she was diagnosed, was actually thrown out of a house to live in the cattle shed because the family was scared that if anybody knew she had leprosy and was living in the house, that their children wouldn't be able to be married. And that's not an isolated event. That happens. People lose their jobs.
And I met a fellow in Bangladesh and when he was diagnosed with leprosy, the local people in the village leaders came to the house saying they were going to shoot him.
Oh dear.
So, and then there's many other stories. I mean, I remember a lady I met who was with her small children, was literally thrown out of her parents-in-law house and lived for 2 days on the doorstep, and even that her mother-in-law didn't even take notice of her grandchildren crying. I mean, I think it's the most extreme it gets, really, in terms of stigma.
So, I mean, the way you're describing that seems, and you mentioned, Sian, the cultural, it's entrenched, there's a massive inertia associated with that. What is the mission doing in terms of overcoming that? It's a very noble thing to overcome. How are you going to tackle that?
Well, we do a lot of sort of community-based work, community-based awareness programmes, quite often using sort of drama in local communities to tap into the sort of cultural side of things. That's a really effective way of tackling things. But awareness about the disease still doesn't automatically break down stigma. I mean, I've heard of people who've gone to doctors, clearly who know about the disease, but the doctors have refused to touch them and examine them. Doctors know about the medical side of the disease, they know they're not going to catch it, but there's still that stigma is so deeply ingrained that sort of untouchability. So it needs to be more than just the head awareness. It has to change people's hearts, and I think that's the big challenge. It's a long-term process. So what we found is very much you can't just go and do an awareness activity within the community. That's not going to change things. It has to be an ongoing programme. Right. But that ongoing programme does work. So I can give an example of a lady who I met in India who I was looking at part of the evaluation of a project after 5 years, looking at sort of various interventions that gone in the community in terms of supporting people into livelihoods so they'd be more respected in the community. One of the things we find is if people have, if they're not begging, if they have decent employment, there's less likely to be stigma. So looking at the livelihood side of things, trying to get children integrated into school, and lots of awareness, and also bringing people together. So things like self-help groups, where they're general groups where we manage to integrate somebody affected by leprosy into them. And people get to know them as people rather than the person affected by leprosy who lives on the edge of the village.
Yes.
But those things take time. But they do break down stigma. So as part of the evaluation, I asked this lady, what's changed as a result of this programme for you? And she'd been involved in various aspects of it. Her son was now going to school. She now had a livelihood selling milk, and people were buying from her. But actually what she said to me, what had really touched her, was that she had friends. She'd been on the edge of the village, no one would ever visit her. Now people dropped in and drank tea with her.
Yeah.
And that is a real sign that the stigma has broken down. Yeah. But it was a 5-year programme working in that community to make that happen. Yeah.
What type of partnerships would you look to make on the ground in those countries then? Because who do you involve in that kind of, you've got the lead position, but who would you involve?
I think what we need to do more of is to work more with general general development organisations who are already working in communities where there are people affected by leprosy.
Oh.
So if we want to scale up what we're doing, work with those organisations who are already there, but make them more aware of leprosy, more aware of the stigma, and how they can actually go about to integrate people into their programmes and break down that stigma within those communities. We can't be everywhere as the Leprosy Mission, but there are plenty of people already doing general development work. And if we can make them more aware of the issues and how to address them, then we'll be able to scale up the impact of the work.
And if possible, work with them. We had a very successful programme in Bangladesh, which we provided a leprosy and disability component as part of a consortium in a food security programme for ultra-poor women. And the result of that is that 900 people affected by leprosy were included within this livelihood programme, and about 20% were people with disability. And you compare that to another big institutional funded project in Bangladesh where the figure was about 3% for people affected by disability, and shows just by coming together with other organisations and giving our expertise into what they're already doing, we can help them reach the people that need help.
The fact that you're going to be presenting at the co-infections meeting, and that particular meeting, as you already know, is all about the healthcare system and looking for intersects and looking for augmentation and looking for, on the basis of these partnerships that you've mentioned, the success of the Bangladesh project and how you described the what you're looking to do over a longer term basis. What kind of partnerships would you envisage would be suitable or roll out to in terms of yourselves and other INGOs in different disease settings? I'm talking about things like lymphatic filariasis as an example with leprosy. There's HIV communities and leprosy overlaps. Would you be looking to make those partnerships?
I definitely think in terms of the stigma and the mental health side, looking at potential partnerships with HIV could be a way forward. In terms of NTDs specifically, lymphatic filariasis is the big link, particularly in terms of self-care. We've already looking at, we've got started a project in Mozambique that's working with people affected by leprosy and people with lymphatic filariasis and other disabilities in terms of supporting self-care groups and then moving on to look at livelihoods, etc. But I think the commonalities of self-care.
And I think the other thing is, in terms of intersecting inequalities, is in terms of the people affected by leprosy, you very rarely meet somebody who is middle class or a richer person. It's not impossible, there are some cases, but the vast majority come from your poorest sector of society. So the people with leprosy are generally from the most remote places, they're from the poorest communities, they're often low caste, they're often tribal. So these people throughout the world are the people who are most likely to catch every other kind of NTD, more or less, because they're those poorest sector in the poorest living conditions, the poorest people. So actually, when we're working in a community, the people that we're working with who are affected by leprosy will be affected by other NTDs. So even ones which don't relate so closely in terms of our interventions, it would still make sense to have some interlinkage because the same people will be affected.
And I mean, speaking about the interlinkage, it's kind of a natural gravitas towards sharing of data, sharing of knowledge between organisations at the softer end of the spectrum of partnerships. Right? Is the concept of data sharing. In the future, how do you envisage the role of data?
I think one of the key things is looking at how we can use data in terms of mapping. So I'm sure, just as we're looking at mapping leprosy, I know that some of the other NTD communities are looking at mapping the other NTDs. And what's really important now is that we look at overlaying those maps. So we can look at key areas of intervention that have particularly high prevalence of numerous NTDs, and then look at, okay, these are the areas that we really need to target. And I think that will help us prioritise where we work within countries and target specific communities within those areas.
Yeah.
And I think that's a real key for moving forward in terms of the use of data.
And even in collection, if an organisation's collecting data and going house to house, even if it's something quite unrelated to leprosy, such as perhaps trachoma, if they could collect at the same time information on leprosy, and I think actually if other organisations are thinking of that, if they could make it known earlier, so potentially we could contribute some funding to the leprosy part of that, and other organisations could do likewise.
Part of our work is looking at how we can develop strengthen health systems. So particularly providing training for government health workers in leprosy. And we have numerous training centres, particularly in Asia, in India, Nepal, Bangladesh, where we have physical training buildings where people come to our hospitals and learn about leprosy, but also even in the African countries where we don't have physical training centres, we are providing technical capacity to the government, supporting the leprosy control programmes and developing the expertise of staff.
We call it a fellowship, so we have a number of countries which are part of the fellowship, and they each have an independent organisation there. So TLM Nepal is registered with the government in Nepal.
That's brilliant.
And they make the decisions really. We seek to support them in it.
Absolutely.
And at times give some advice and say, what about this?
Fantastic.
For example, we're bringing Diana from TLM Nepal across to the co-infections meeting. Again, it's to give an opportunity for them to share.
And most of our staff in country are locals, and so they know the context, and they are able to then develop good relationships with the government to then be able to support them.
What would be the role of governance the ideal role for you guys in terms of what could they do more?
Well, we don't want to be paying the government to do their job.
No.
So very much our role is to encourage the government in that country to take action. So whether that's by working with the government to change laws, such as India, they're working with the Leprosy Mission India, were working with the Law Commission to amend discriminatory legislation against people affected by leprosy. And so again, that's a bit of advocacy. And actually now it's in with the Indian government, really.
That's fantastic.
And then on the other hand, in Nepal, for example, with a new project that we just started supporting, is to extend the PEP, the single dose rifampicin trials to southern districts in the Terai. And the way that's working is essentially it will all be done by government people. We're actually just supplying a little bit of extra funding to fund some facilitators to work with the community and just to give them the resources to do their work. So we're not providing any government salaries. And so most of the work is done by the government. We're just giving it a help. In Sri Lanka, it's similar. We're doing screening in the north. So it's the government people that do the screening. But before the screening happens, our partner does drama and awareness so that people are aware that the screening is coming. And after the screening has happened, our partner follows up to make sure that those who've been identified actually go to hospital and get some support when they come back. And they also help with the practical arrangements when the screening happens. So our role is very much to support and push national governments to do their job. And I think, we're achieving that.
I think the challenge we've got is that there's still a lack of political commitment in most of the countries we work towards leprosy. And that really stems from the WHO's elimination target. So by the WHO setting the elimination target that leprosy has been eliminated as a public health problem once you get to 1 case in 10,000 of the population. People are working to targets of not finding leprosy. And when your target is not to find it, you don't find it. And once countries reach those WHO targets, okay, leprosy is not a priority,
Yeah.
and it's sort of publicised in the media. You know, leprosy's been
Leprosy-free,
eliminated.
yeah,
We're
yeah.
a leprosy-free country, and people don't actually realise that in India we've still,
is, yeah.
you know, we've still got 120,000 or more
Yeah.
new cases every year, and yet it's eliminated. And so there's no, and the government then don't think that there's a need for a significant investment in training medical health
see.
workers. Health workers are therefore not trained, and then even if they get a case of leprosy, they're not able to diagnose and treat it.
And the government doesn't
Great
then
percent,
want to
yeah.
then go back over that target. There's an incentive to actually not look for cases.
Yeah, but they need to be the right targets.
Yeah.
I mean, WHO now have realised the issues, and the new strategy is going to be very much focused, and still is focused, on looking at incidents of disability
Yeah.
as a result of leprosy and changing that focus.
Um,
But I think, you know, in many cases the damage has been done, and the challenge is how do we actually convince governments that leprosy is still a
not,
problem
yeah.
and that they need to be addressing it.
I think it's a very interesting point you've raised there, in the sense that for many years we all saw that the pegging of leprosy to the disability world was very, very strong association for obvious reasons. The last few years it seems to have come away from that, and it just felt that there was more of a move to the NTDs as opposed to the peg to disability. And yet this year we've seen it kind of snap back into that relationship with disability programmes. And this is from a consensus position. This is what we were seeing from lots of different areas. For the next 5 years, in terms of outlook, how close will the association, in your opinion, be between leprosy programmes and disability programmes in these particular communities?
I think it's very close. I mean, we have two aspects to our vision. So leprosy defeated, lives transformed.
Yeah.
So we're very much looking at the disease focus,
Yeah.
and that will be where we would obviously work with other NTDs. But also looking at the lives of people transformed, looking at those who have been disabled by leprosy,
Yeah.
and therefore working with the disability community
Yeah.
to ensure that disability is tackled in the communities where we work. Again, you know, you can't just go into a community and work on leprosy.
Yeah.
You have to be looking at a holistic approach to community
Absolutely.
development, to address stigma, but also there's many other people with disabilities within those communities. It's not cost effective just to work on leprosy. So it's really important that we do link with the disability community, but we can't neglect the disease element.
Yeah. Yeah.
And I think you're right. I think there was a time that we were, the leprosy community was very much focused on the disability side, and
Yeah.
perhaps to the extent that there wasn't sufficient focus on eradicating the disease. And I think now we're starting to get the balance a
Yeah.
lot better.
So in some cases you'll get a complete overlap between the three. I mean, if you're talking with lymphatic filariasis and
Yeah.
people who've got elephantiasis, and
Yeah.
then obviously they're also with disability and NTD. And
What type of partnerships in disability do you think, moving forward, will you guys be looking at or looking to get involved? You've mentioned things like drama. Still, perhaps that's more for the stigma side. But from what type of partnerships?
Particularly in relation to community-based rehabilitation.
Rehabilitation. Yeah. Yeah.
So that would be probably the main focus, but obviously we're also working with lots of other disability organisations already in terms of advocacy. So through IDDC, International Disability
Yeah.
Development Consortium, and also groups like the Bond Disability and Development Group within the UK, working to influence DFID on their disability framework, etc. So we're already involved in many of those networks in terms of advocacy, but I think that there's more that we can do in terms of partnerships, particularly in relation to disability in the field at programme implementation level.
The reason I asked that, I'm going to go back to the rehabilitation part of it, which seems very important. You've mentioned it. I know it's on your site as well. It's got some of the messaging that comes out. Elements of rehabilitation would be, in my opinion, what you take people, they go back into the employment stream. Could you please elaborate a little bit on that, just to?
Yeah, I mean, there's various aspects of rehabilitation that we'd be looking at. So the first thing you think of is the physical rehabilitation, and obviously that's
Mobility,
important,
yeah.
particularly in terms of reconstructive surgery and those sorts of aspects which we're very heavily involved in. But yeah, looking at livelihoods, so how can people get into employment? We've already mentioned that people who are employed are less likely to be stigmatised if they're in a decent job than if they're not. So employment's a really important part of that. Education, making sure that children of people affected by leprosy are going to school, but also looking at skills training, vocational training. And one of the big areas that we're focusing on as the leprosy mission is in terms of empowerment. In bringing people affected by leprosy together to share their experiences, to speak out, have a voice. We very much feel that it shouldn't just be the leprosy mission speaking at forums, it needs to be people affected by leprosy themselves advocating for change.
I think that's perhaps we missed that a bit. You know, when we're talking about sustainability, is one way we're working at sustainability is actually working with leprosy people's organisations. So we're very much trying to strengthen those that exist, such as in Mozambique, Ethiopia. And we're about to start a capacity building project with the Leprosy Association in Nepal, and also with disability organisations. In Myanmar, we're working with the National Umbrella Association, which brings together all the different disability organisation associations, and working with them to actually ensure that the government brings in. There's recently been a new Disability Act that's come in, which we've pushed for, and working to see that it's actually enacted on disability in the national census in Myanmar, which was a first. And so we're working with them, and then by working on disability in Myanmar, then people affected by leprosy are brought into that. And one very successful thing is actually, instead of working just with leprosy people in a group, having a group of mixed disabilities. And I remember visiting a group in the Mandalay, near Mandalay, which had about 2 or 3 people affected by leprosy, parents of children with cerebral palsy, various different disabilities, including people who had just been involved in road accidents. And so what happens in that context, by working with the other disabilities, is leprosy just becomes one disability among many. So just the process of having a mixed group actually reduces the stigma.
You've mentioned employment, education, empowerment as 3 principal areas of your rehabilitation strategy. What could be the potential role of locally based, the local private sector in the endemic countries in rehabilitation programs?
Well, in Myanmar, the one of the projects we've got there actually has done training for various businesses. So they actually include people with disability and leprosy within those businesses.
And did you push for that? Did you say to them, this is what we want you to do, this is what we're doing, these are the benefits?
And actually, it turned out that the businesses were much more interested in doing it than the other NGOs, because we also had the same thing for the NGOs, but they were actually much more successful with the businesses and then working at inclusion within that. And
in India, we've had vocational training centres, which include people affected by leprosy, disability and other marginalised groups. And they work very closely with employers to ensure placements during the time when they're there, but also have links once they've completed their courses to employers, and looking at fair labour and those issues, as well as making sure that they are disability inclusive in their employment. And that's the sort of model that we'd like to look at. We're just working on a new programme at the moment in India where we're looking at taking that to a step further to sort of look at how we can actually demonstrate good practice in inclusive employment, and then roll that out so other organisations can actually see what this looks like in practice.
You've mentioned the Disability Act, you've mentioned this behaviour change in terms of employers looking at this from without the burden of stigma to these patients, bringing them in, the affected people. Is it an economic case that needs to be built?
I think there is definitely an economic case. Whenever you're working with business, you can't ignore economics. They're not going to do something if it's not profitable to them. That's just the hard facts of it. So it is essential that we do look at the economic case, but it's not just the economic case of inclusion, it's also the economic case of exclusion. And particularly in terms of government, if people with disabilities are not included in employment, and you're having to pay social services welfare support for them.
Yeah.
That is actually a cost to
Yeah.
them, not to the government, to them not being employed. And actually, the amount of income that you actually lose through having people who are not productive in their
Yeah.
communities is huge.
Absolutely.
So there's a huge cost to exclusion. So I think helping people to understand that
Yeah.
is really, really important.
How far do you think it's going to swing and stay at the private sector, and how will that impact the leprosy mission? It's a big question, because we're talking about the future and the evolution that basically is required of NGOs or charities, the entire sector.
I think as far as most of the leprosy mission income at present actually comes from individuals and churches. We're as a faith-based organisation, that's our strong support. And actually that is growing, but clearly not growing enough to be able to do what we need to do to tackle the leprosy globally. So we do have to look at how we actually work with institutions in the private sector to take things forward. And I think the partnership approach is a really, really important way of doing that.
Yeah.
We need to be convincing large pharmaceutical organisations like Novartis to be doing more, to actually supporting, particularly in the area of research, looking for new drugs.
Yeah.
Particularly at the moment, we have a big challenge with treatment for reaction. We need new drugs for reaction treatment for leprosy. There are a lot of areas, we've already mentioned diagnostic tests, that we can't do as an NGO sector. We have to work with the private sector to do that. And I think that's really essential.
I mean, you mentioned a very, very nice inroad in terms of the rehabilitation programmes. I mean, I've come back to that, this is the third time. I think that's a fantastic opportunity in terms of engaging, really with a really important part of the private sector, the part that no one looks at. People look at the multinationals and the CSR, but it's really the grassroots people, isn't it, in those communities?
Even, we're doing a lot of community-based vocational training, and part of that is actually placing people in small businesses. So if someone wants to train with a hairdresser, we bridge that link with a hairdresser and support them to do training in that local community. So working with very, very small businesses is a really important way forward. Quite often the informal economy is actually an important railroad in.
Yeah, we mentioned 3 issues there, 3 parts of your programmes: education, employment, and empowerment. So that's employment, and how about education then?
Our focus on education has been more to do with breaking down stigma. There are relatively few children, thank goodness, who are disabled by leprosy. So in terms of inclusive education and things, that's not a major part of our work.
Okay.
It's more about breaking down the stigma to ensure that children can access school.
Okay.
But certainly in terms of empowerment, one of the things that we're looking at is partnership. We actually have a partnership at the moment with Leeds University, where we're looking at issues of stigma and how can we break down the barriers to stigma and empower people affected by leprosy.
Okay.
So that's one of the areas we're looking at. But we are looking at expanding our partnerships with universities. We're exploring at the moment a partnership with Liverpool School in terms of looking at leprosy and lymphatic filariasis in Mozambique.
Yeah. That's fantastic. Would you look for universities in endemic countries?
Yeah, I think that will be a really good link, particularly if we've got a three-way partnership with an academic institution here in the countries where we're working. Yeah, we're developing links at the moment with one of the universities in Colombo to explore potential research opportunities there.
In August 2015, you reviewed a detailed article in collaboration with WaterAid on the importance of water, sanitation and hygiene for lymphatic filariasis and leprosy care. In terms of inclusion. What was learnt? Does the stigma get worse if you've got both diseases?
Probably in most places, the stigma associated with other NTDs isn't as high as it can be with leprosy.
Okay.
But in some places where the leprosy stigma isn't quite so high, there may be higher stigma in other things. It can be on a similar level. In Bangladesh, when we looked at the food security project and the people involved, the researchers found that in that particular area, the stigma associated with leprosy and the stigma associated with any kind of disability was very similar. Now that was because that area's got quite a lot of leprosy, so the leprosy stigma is less than other areas, but also in that area I think the stigma associated with other kinds of disabilities was quite high.
Okay.
So I think sometimes it can be very similar, but I don't think with a general case of disability in the case studies I've seen, the stigma rises to the potential it can with leprosy.
The reason I was asking that actually was because I suppose the question asks itself that is there a panacea? Is there some kind of unified approach to handling stigma, or decreasing stigma, in these communities? I asked that because you said you've got drama programs, so what's out there that we could do?
I think there are common approaches, and
Yeah.
I think whenever we're looking at health awareness programs, it's important not to take a single disease approach, that we do need to be looking at other diseases in that context, and that is how we work as the leprosy mission within communities.
Yeah.
We very much look at what are the diseases actually that are issues within that community, and when we're doing health awareness, leprosy will be one of those components.
Yeah.
And again, that's a good way to break down stigma and not just be highlighting leprosy as an issue. It's just one of many issues. So the whole approach is of all the things that we've said about getting people back into work to make them feel more productive in themselves and actually the community look on them as productive citizens is important, whether that's a disability due to leprosy, lymphatic filariasis or a car accident. The approaches, the interventions can be very similar.
Okay.
And just to add there, sorry, we also have to kind of bear in mind we don't have the answers all the time, so we'll have to look at others like HIV, things like that, how they did their work. We need to look at their research, see what evidence they have, and try to replicate it towards people with leprosy to see would it work, as there was what they've achieved, can we replicate that?
An example where we have done that in a small way is with working with one of our partners in Sri Lanka. They were actually working on a project on HIV, on stigma reduction. So it was then that Sian suggested they might do something on leprosy as well, and so they have used their expertise and their experience on working with HIV to then focus on leprosy. Generally I think in terms of our community work, you can't just look at leprosy in isolation. You have to look at the well-being of the community, and so the well-being of all the people affected by leprosy within that community and their neighbours. And when we're doing general awareness work, such as our other partner in Sri Lanka, KKM, is doing general hygiene and health awareness in leprosy affected communities, and because dengue is a huge issue in Mana district in particular, they've actually included awareness and dengue as part of their awareness. It started as a cultural organisation with working with people affected by leprosy, so their big thing is drama. The other thing about KKM is they don't just do drama for awareness, they do something called playback theatre, where someone tells their story of, difficult story. I mean, in the context of KKM, it might be related to the conflict, it might be related to leprosy.
In terms of the drama approach, the drama element that you guys have brought into the programmes that you've got, leprosy awareness in Sri Lanka, you've mentioned KKM.
Kaveri Kalamanram.
Could you elaborate a little bit on that in terms of what?
Well, Kaveri Kalamanram started off as a cultural organisation working with people affected by leprosy and actually using the arts to reduce stigma and to raise awareness. But they also deal with the trauma and the healing of the person emotionally through their playback theatre, which is really something that the leader of that organisation, Reverend Joshua, has very much developed himself. And so they will ask someone to tell their story, someone affected by leprosy and how they've been discriminated against, their pain, and then their KKM drama team will then actually reenact the story, and that will happen repeatedly in the meeting, and it's a one way of getting healing, of also getting the issues out, of aiding discussion.
And that is local to areas of Sri Lanka, or
In KKM is based in the northern province, and actually they also target youth. So in Manor district, where they've just extended their work to, there's now 70 drama groups with young people. So they use the youth because the youth don't tend to travel for work. They know they're going to be there for a while, and also the youth, they have passion, and interest, and they do these dramas in their own communities, and they're trained to do that. And the other thing I want to say about KKM is, one thing I attended was their New Year. The Harvest Festival. I attended the Harvest Festival celebrations that were put on by KKM, and at one level you look at it, and it's the very typical, Tamil, Harvest Festival festivities. But when you look at it at another level, you realise that about half the people involved in the dancing, in the competitions, in all the cultural events are actually people affected by leprosy, and they're doing this cultural festivities side by side with people from the community who aren't affected by leprosy. So actually, just through this event, it's actually bringing people together and reducing stigma. So it's very, very clever.
So we live in an age of migration, right? Migration linked to our, very existence even in Europe at the moment, right? The whole Brexit issue seems to be mired in issues around migration. We've seen a lot of research coming out recently from Liverpool, actually, about the re-establishment of diseases such as leishmaniasis because of conflict and because of mass urban migration outside, of these conflict areas. What's the outlook for leprosy in your mind? Will this have an effect on leprosy?
Certainly, the conflicts had effect in Sri Lanka, and I've met somebody whose course of NDT was interrupted because he had to move, and then his leprosy came back. And so in terms of the spread of leprosy throughout the conflict-affected areas, certainly as people moved around, it seems that leprosy has been spread.
And if you're in refugee camps, etc., it's perfect cases for leprosy to be spread in those, as you say, environments where there's poor hygiene and sanitation, where people are perhaps not getting sufficient nutrition, where there's overcrowding.
And you've got to remember, a lot of the places where if people are migrating in between, there's still going to be that stigma about, and no one wants to really come forward and say, I need support because I've got this. They'll want to keep moving on, so trying to track that person is going to be very difficult to do.
Especially when you've got multi-drug therapy that just takes between 6 to 12 months for treatment. Ensuring that people actually carry on with their treatment in those circumstances would be nigh on impossible.
And I think rural to urban migration as well, which has been going on for much longer, really, and is increasing. I mean, because you find a lot of your high pockets of leprosy are in, your urban slum areas.